Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Strategies for Optimal HIV Treatment and Prevention, answering the questions on managing ART failure, featuring Dr. Daniel Kuritzkes and Dr. Cristina Mussini. Dr. Kuritzkes is the Harriet Ryan Albee Professor of Medicine at Harvard Medical School and Chief of the Division of Infectious Diseases at Brigham and Women's Hospital in Boston, Massachusetts. Dr. Mussini is a professor in the Department of Infectious Diseases at University of Modena and Reggio Emilia in Modena, Italy. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Kuritzkes and Dr. Mussini have to say.
Well, thanks very much, Jessica. It's a pleasure to be speaking to you today together with my colleague, Dr. Mussini. And let's start with a discussion of defining some terms. And here we're going to talk about the difference between a virologic blip, low-level viremia, and virologic failure on ART. When we have patients whose virus loads are not fully suppressed between 50 and 200 copies, it's important to assess their adherence to treatment, to question whether they may be taking any other drugs that could be leading to drug-drug interactions, or whether there are other infectious processes going on that are causing immune stimulation that might lead to a transient increase in viremia. Of course, you'd want to repeat the virus load, and then this may lead to one of three different outcomes. Either the patient is once again completely suppressed with less than 50 copies, in which case you can say that brief period of detectable viremia was merely a blip, and you can continue to comfortably just monitor them and periodically assess their adherence. The more challenging situation is when there is persisting detectable but low-level viremia, and here by low level we mean between 50 and 200 copies. And we're learning more about what causes this situation, and it's not ongoing virus replication in the great majority of such patients. It's really continued release of virus from the reservoir, but without new cells becoming infected. And so there's little chance of resistance in this circumstance. What is concerning is when somebody has more than 200 copies, because that typically means that there's evidence of virologic failure. And in this situation, you'd want to perform resistance testing, usually by getting a genotype, and then modify the treatment regimen based on the results of the resistance test, as well as your assessment of why this person is experiencing treatment failure. Well, fortunately, with today's first-line regimens based on integrase strand transfer inhibitors, or INSTIs, failure with resistance is extremely rare. We know from clinical trials data that in the case of bictegravir, there have been no cases of treatment-emergent resistance to bictegravir in the phase 3 trials, either as initial or switch therapy. And in dolutegravir, likewise, there have been no cases of treatment-emergent resistance to dolutegravir in the SPRING 2 or single studies, which looked at initial use of a triple drug regimen with dolutegravir being the INSTI. Gemini 1 and 2 were the phase 3 trials of two-drug therapy, dolutegravir 3TC, in treatment-naive individuals. And over the long period of follow-up, just a single individual out of 716 developed evidence of treatment-emergent resistance. And none of the 717 patients in the control arm, which was where people received the triple drug, developed resistance. And then if we look at real world data, there are so far 2 case reports of resistance to bictegravir and a limited number of case reports of resistance to dolutegravir, one in a person with very high virus load at the time of primary infection. Most of the others are really in the setting of dolutegravir monotherapy or dolutegravir used in salvage regimens. But what are potential reasons for the failure of an antiretroviral treatment regimen? First and foremost are patient and adherence-related factors. And adherence, of course, can be driven by many issues that make people's lives complicated. These include psychosocial factors, in unstable housing, trouble accessing medications and occasional stockouts in certain parts of the world, adverse events that cause people to interrupt dosing because of intolerance, a high pill burden and high dosing frequency, comorbidities that may also interfere with taking medication or cause drug-drug interactions. And then, sadly, for many people, cost and affordability remain significant barriers to care and barriers to access to medications and therefore to adherence. There may be virus-specific factors. These include transmitted drug resistance or acquired drug resistance due to failure of prior regimens. Very high levels of viremia as occur in primary infection, as I just mentioned. Innate resistance and prior treatment failure. And then lastly, there are regimen-related factors, and these include suboptimal pharmacokinetics of a regimen. That's not very common nowadays. It was certainly a big issue with regimens that we used earlier in the HIV pandemic. Suboptimal virologic potency. Similarly, today, that is rarely a situation, but it is something to be concerned about. There are regimens that have varying barriers to resistance. Some regimens have a high barrier to resistance, some have a lower barrier, and that can influence the likelihood of resistance at the time of treatment failure. Some regimens have food requirements in order to optimize absorption of the drug, or conversely need to be taken without food to prevent interference with drug absorption. And then, as I mentioned, drug-drug interactions, and Dr. Mussini will have more to say about this. There can also be prescribing or dispensing errors, and this is much more common when looking at multi-tablet regimens where individual prescriptions need to be provided for each component of a regimen. And there can be reduced efficacy due to prior exposure to suboptimal treatment, essentially a less effective regimen that led to treatment failure and selection of resistance. But what about poor adherence as a reason for first-line INSTI-based treatment failure? We can see on this slide that analyzed the relationship between adherence and treatment failure with the bictegravir FTC-TAF as a fixed-dose combination. This was a single-center retrospective analysis of just under 300 people, all of whom were receiving this regimen. And you can see that the likelihood of having a target always undetected or being less than 50 copies significantly increases as the adherence increases, and making the point that the more adherent you are, the more likely you are to maintain viral suppression. We also have data relating adherence to response to first-line dolutegravir-based regimens, in this case from the Gemini 1 and 2 studies of two-drug therapy with dolutegravir 3TC. And again, looking at the distribution of people who had greater or less than 90% adherence on either the 2 or the 3-drug regimen, you can see how much more likely it was to be fully suppressed if you were highly adherent compared to having suboptimal adherence. Regardless of the level of adherence, there was no significant difference in outcome between the 2 and the 3-drug regimen. So the key point here is adherence, not the number of drugs in the regimen. Well, let me turn this over now to my colleague, Dr. Mussini, to talk to us about drug-drug interactions.
Thank you, Dan. When we talk about drug-drug interaction, we cannot avoid thinking about the Liverpool tool that we have all in our phone. I think that it's important to see that apart from some, well-known drugs that could have interaction like rifampin or things like that, or the St. John wort, I think that it's important to have a look at the website when we counsel our patient, because there are some specific interaction that are related to drugs that sometimes are not even mentioned by our patients. And some of these are for sure multivitamins, iron supplements, calcium supplements, magnesium supplements, and antacids. Antacid is something that we are used to see. For example, when we had atazanavir or rifampicin or ripivirin, But we have to think that even the second generation INSTI could have interaction with these drugs. But what I really want to underline is that in many cases, they are not reported to us if we don't ask. And so it's important to know that divalent and trivalent cations can bind to INSTI in the gastrointestinal tract, decreasing absorption. And either bictegravir or dolutegravir can be taken simultaneously with food. And when they are taken with food, it is safe to take also multivitamins, iron, or calcium-containing supplements. But the problem is that many of our patients, they don't think that these are drugs. The supplements very often are not taken with food because it's thought not to be a drug, no? So, and bictegravir or dolutegravir, they have to be taken 2 hours before or 6 hours after antacid or supplements containing aluminum or magnesium. This is something that we really should keep in mind when we counsel a patient, when we start a treatment, together with the toxicities to the possible side effects. We have also to give advice on these non-drugs, but that they are often taken by the patient. And how often they are taken? We conducted this survey that we recently presented at the Italian conference on HIV, but just we wanted to understand how frequent is this phenomenon, how frequently our patients are taking supplements. And for supplements, you can see cations, herbal supplements, vitamins, amino acids, or others. And if you see among 267 responders to the survey, 120, so just a few less than half of them, are taking these supplements. And this is very, very relevant. And especially they take cations, about 62% of them were taking cations. It's very, very relevant to see that in our small study, single center study, there was not an impact on the virologic outcome. But it's important to understand that about 44% of our patients in a way were taking these supplements. And we have to ask it for them. There are other co-medications that can significantly decrease bictegravir and dolutegravir concentration. As I said, St. John's wort, it's something that people my age who are in the HIV field for a long period of time, they know about it since indinavir. But it's important to think also about anticonvulsant like carbamazepine, oxcarbazepine, phenobarbital, phenytoin, and obviously, as I said, rifamycin. If the patient has just come back with a higher viral load, so it started with 610, and the following one is, let's say, 1,000 or 1,200, something like this. So if he is experiencing virologic failure requiring an ART change, what would you do? So for the DHHS, selection of antiretrovirals with failing regimen, it's obvious since many years that it's really wrong to add only one antiretroviral to a failing regimen. It's absolutely not recommended. It's recommended either to have 2 fully active drugs or 3 fully active drugs, even better. I think that now, with all the data on the 184V, we know that even two active drugs could be enough, I have to say. Also with the data on 184V negatively impacting the fitness of the virus, so the replicative capacity, I think that 2 could be enough. But if it's possible, even 3. What do you think then?
Yeah, no, I agree with you. I think that's exactly right.
Mm-hmm. So, the most important thing is to understand what is fully active. Okay. There is a question that says, what is the role of proviral DNA testing in this type of setting with low level viremia? I mean, I think that, fully active, it's something that means that the patient never failed on that regimen developing resistance, because sometimes in the RNA, this mutation could have disappeared, but maybe they are still there in the DNA. So I think that fully active is really a drug that has never been seen by the patient, and he has never failed on this. So no previous resistance or treatment history of resistance testing. It may include newer members of existing drugs or new classes, or a new mechanism of action. So, which are the key take-home points from what we said until now? Bictegravir, FTC TAF, and dolutegravir containing regimens have very high genetic barrier. So as we said, we are not scared of a low level viremia failure, making failure with resistance in first line INSTI-based ART uncommon. First line, second generation INSTI-based ART uncommon. Because unfortunately, the few mutations that are circulating now are related to raltegravir, not obviously to dolutegravir or to bictegravir. With virologic failure, patient counseling is critical to determine what is going on. I think that it's even more critical, as I said, to counsel before starting a regimen. It's important to reinforce adherence, and it's important to talk about drug-drug interaction, because the drugs that we were talking about are not perceived as drugs by the patient. When switching ART because of a failing regimen, include 2 fully active antiretroviral as long as more than one of them has high genetic barrier to resistance. I really think that when a patient has failed a regimen with, for example, a lower genetic barrier, I would say rilpivirine, it's important to include in the regimen a drug that has a very high genetic barrier, that is the real backbone of the new regimen. And prefer to include 3 fully active drugs if no agent has high genetic barrier to resistance. And this I completely agree. So now is the time for the question. As I said, the first one is, what is the role of proviral DNA testing in this type of setting with low-level viremia? I would ask something different also to you then, and I will talk about this. Now we are talking, for example, about long-acting, okay? And many patients many people living with HIV are asking us to switch to injectables, even if they have a very long treatment history with several failure. What do you do? If obviously they have to be undetectable. But what do you do? Do you do DNA? Because we do DNA, I have to say.
Yeah, I think that's a great question. I think proviral DNA testing has really been trying to find its niche. And I think the challenge is that the test is only partly reliable. First of all, we know that only a tiny minority of the circulating lymphocytes actually carry HIV. And then most of the proviral DNA that is found is defective. And so you're really looking for a needle in a haystack in a way. And if you find evidence of resistance, then you can probably be pretty confident that there were viruses resistant to that drug that circulated at one time in the patient, and that there's a risk of relapse if you reuse that drug or use a drug to which the virus is resistant. But not finding anything, seeing just wild type doesn't guarantee that you're not missing a minor variant. And that's much more of a problem with proviral DNA than with plasma RNA. But the problem can also go the other way. So, for example, we have a patient that my colleague John Lee and I have followed closely, who has persistent low-level viremia because of an expanded clone of wild-type virus. And if we look in his proviral DNA, and when John did multiple single-cell sequences, we could find that there were archive-resistant viruses, but they were not the viruses in the plasma. So he was fully susceptible to the regimen that he was taking, even though there was resistant virus in the past. So it cuts both ways. Now, in terms of long-acting therapies, I agree. First of all, I would tend to avoid switching to cabotegravir rilpivirine if somebody had a history of prior treatment failure on a non-nucleoside ART inhibitor-based regimen. If the patient was really insistent, I think you could do a proviral DNA test. And if you found an NRTI resistance, that would be another reason to dissuade the patient from going on that regimen. If there were only wild-type virus, then you might consider moving forward. So that is probably currently, I would say that the most common use that we have for viral DNA testing is the situation where somebody with an uncertain history wants to go on long-acting injectables.
Yeah, I would say the same, because there are people coming from other centers and you don't have the full history. So we do it, the same, absolutely the same. And I agree with you. It's part of the scenario, the DNA. You don't have to rely on it too much, but it's better than nothing, I have to say. So when the patient is undetectable, it's better to have this. Okay. And so, are there non-drug interaction with herbal medicine? Apart from St. John's wort, I have no clue.
Yeah, that's the main one that we are worried about, and sort of the classic example of drug-drug interaction. But I think we have to be concerned that there can be all sorts of excipients or materials in the pills themselves that are not as well defined because they're not formally approved agents. I think it's always a risk and a concern. There was a question about why is a rise to 610 copies not considered a blip? It's sort of convention. So yes, certainly if somebody's consistently suppressed, one visit they have 600 copies and the next visit they're suppressed again, you could say that was a blip, but the mechanism is probably different because it's unusual for people to get to that high a level merely because of immune activation or because of some of the other factors we discussed. It is more likely to represent a transient period of lower adherence.
And for example, we can sequence also above 100 we sequence usually. Is this the same now for you or not?
I'm sorry, do we sequence with?
If you have a viral load that is 150, for example.
Yeah,
so into sequence.
So the problem is, in the United States, most of our sequencing is done in commercial labs rather than in our own hospital-based laboratories. And because the commercial labs have validated their assays for samples that have 500 copies or more, or sometimes 1,000 copies or more, you can send the sample, but often they might decline to test it if they realize that it's a very low virus load, and there's a high risk of getting a no result. In my own lab, we're routinely able to get resistance test results with 150 copies, but we don't do it for clinical purposes.
Okay. So we have some suggestion from Jorge Santana, who said there is a nice link with FDA for CAM, complementary alternative medicine, which is very helpful. So this is helpful for everybody.
Thanks for pointing that out to us, Dr. Santana. That's good to know.
Yeah.
So there's a little brief case description here from Susan Carr, an 18-year-old patient who was diagnosed a year and a half ago and started on a bictegravir-based regimen, but still had a virus load of over 3 million a year later. I guess half a year later, in February of 23, so a few months later, had a inadequate bictegravir level and evidence of low-level bictegravir resistance. in the setting of what was considered to be complete adherence. They thought about using bictegravir FTC TAF twice a day, but instead switched to a boosted darunavir regimen together with rilpivirine. The patient's virus was susceptible to all the PIs, and now 3 months later, virus load is 11,000 with slightly low darunavir peak concentrations. Thinking about twice daily darunavir ritonavir, and the patient is coming back to clinic in a couple of weeks. I would wait and see what the virus load is. That virus load was so high that it is going to take quite some time to get to completely below detection. So there would be two things to keep in mind. One is the rate at which virus load declines on a protease inhibitor is slower than what we see on an integrase inhibitor-based regimen. It's much more like what we saw, with older regimens like efavirenz or even the unboosted PIs. There are people who start off with more than 1 million copies of virus. A substantial proportion of them will not be below detection even after 24 weeks. It can take up to 36 or 48 weeks. So I wouldn't panic if this person's virus load is still in the low thousands or hundreds. You'd like to see that there's a continuing downward trajectory. If it plateaus and certainly if it begins to go back up, then I would worry. I would stick with the current regimen for a bit longer here.
Yeah, and also I have to say that this sense that we believe adherence is 100% in an 18-year-old person. I'm not absolutely sure that we can, one of the data that you showed from Franco Maggiolo about bictegravir FTC TAF showed that even if they were taking 70% of the drugs, they still can get undetectable.
Right.
So I don't know your experience, but for me, sometimes say, you are really taking very correctly the medication. You are perfectly adherent because your viral load is less than 2 copies. And they look at me like, but yes. So the forgiveness of this drug is very high.
If I'm reading this correctly, the patient was switched to the fixed dose combination of darunavir, cobicistat, FTC TAF plus rilpivirine back in March, and now has the virus load of 11,000.
Yeah, no.
They're considering a switch to twice daily bictegravir
FTC.
And I think that would be a much more complicated regimen because they would have to take the darunavir and the ritonavir separately and then be taking it twice daily. I would wait and see what the virus load looks like on the 21st before making it.
No, I agree completely. And so they say continue with the 18-year-old patient with bictegravir resistant question. Confirm no drug or supplement interaction with full medication history. Low level resistance confirmed with bictegravir and susceptible to all PI. So I would leave only, if it's already on it, darunavir, cobicistat, FTC, TAF. I would not add something more. And probably it just takes time because, as you said, protease inhibitors are slow and they decrease viral load slower than integrase. Other question. I wanted to ask, I'm a student researcher, and I wanted to ask, how long do you typically wait to adjust treatment when you notice a patient experiences heart failure? I noticed some reports say that they wait a few visits. No. For me, if I think that it's a failure, I change it, hopefully on the basis of resistance testing. And, but it's important to understand if it's a failure, because if a patient suddenly come out, he was always undetectable and suddenly come out with 100,000 copies. Obviously, I don't think that it's a failure, but it just stopped taking the medication. So it depends on, because with the drugs that we have now, the failure is just 1,000 copies if they continue to take the medication. If it goes very, very high, usually they stop taking the medication. What do you think?
I think you first want to assess what would be the reason why the person is experiencing viremia. And is this something that's easily remedied? I would get the resistance test. And then I think you have to decide what to do, because it may be that just going back on the same regimen with enhanced adherence counseling or trying to address some of the challenges that the patient may be facing will lead to suppression. But if the person is experiencing some side effects from the drug, then this is the wrong drug for the person, and you need to choose a different regimen, even if there is no resistance. I think there are in some parts of the world where access to both resistance testing and frequent virus load monitoring is more limited. It is common to attempt first to work on increased adherence before considering a switch in the regimen, and that is part of the WHO guidance, especially used in lower and middle income countries. Here in the United States, we, as you do in Italy, we would assess immediately for why there's a failure in it, and then consider a switch in regimen without.
Yeah, also because it's the best way to select resistance to maintain a patient with a failing regimen. So I think that the sooner the better. What about long-acting oral drugs? We long for them, but we don't have them yet.
Yeah, there aren't any at the moment. We'll have to see what happens with development of islatravir as a potential drug that could be given once weekly. But because of some of the toxicities, it's not so clear where that's going these days. It's much more challenging to develop a long-acting oral formulation than long-acting injectable or depot formulations. And so I think we're not likely to see very long-acting oral drugs. And chances are the best we will see would be once-weekly regimens.
Mm-hmm. So what is the best and most practical adherence tool to use? One easy is the VAS scale. It is it's like a line, and the patient has to cross at a certain point of the line if he thinks that his adherence has been 100%. This is very easy. But I really believe in dialogue. You have to talk to the patient. It's not that you are judging the person. You just want to maintain his viral load undetectable. So the idea is to create an alliance between the doctors and the patient in order to, I can accept this. I always say, if you are tired, if you don't want, just taking all the risk of a detectable viral load, so you can be effective and whatever. But I usually say, don't take half of the medication. Don't make some messy thing, because you can develop resistance. So it's better not to take it for 1 week than to take it very randomly. I don't know if it's, obviously explaining about U equal U, and that if his viral load or her viral load increases, they can transmit.
I think from a patient perspective, as far as tools are concerned, obviously pill boxes, especially if it shows you which pill you've taken each day of the week. Sometimes there are some apps that people can use on their cell phones. There have been a number of studies that have looked at text or SMS reminders, and those have failed to show any real dramatic improvement in adherence or in treatment outcome. But there are individual things that patients can do to remind themselves to take their medication.
I've understood what is from the doctor.
Yeah, right. No,
measure at the end.
I think we've covered it on both sides. Yeah.
No, I agree with you that, but it's, I think that, each one of us, when we have to take some medication, we have to, find our own reminder, because outside of the clinical trial, it is not so feasible that clinical centers call the patient to remind the medication. Right. That is not possible. So it's just maybe setting a clock on the phone or something like this.
And the other guidance that's very often given is that patients should find another activity that they do on a daily basis to which they can link their medication administration. So whether that's brushing your teeth in the morning or if you take meds at night, when you get washed to go to bed, something that, because you're doing the same thing every day, you'll remember this is when I take my medication.
It makes mechanical. Yeah.
Better for some people than for others. And it depends on how regular your life is. If you have a more chaotic life, that becomes more difficult. There's another question here that asks, what are some other reasons that patients can experience viral rebound if they claim to be adherent and there are no concerning drug-drug interactions? So a transmitted resistant virus would certainly be one, but that wouldn't cause failure to occur, months later. And if it's true rebound and not just a blip, then immune activation would not be an explanation either. Unfortunately, I think, unless you are able to get drug levels, it is very hard to know for certain that the person is absolutely taking the medications the way that they have been prescribed. And it's far more likely that they were not taking the meds. And one reason we know this is if you look at some of the trials where people have had viral failure and no evidence of resistance at all. And this is with older regimens, not the current INSTI regimens, where you would expect there to be resistance to, say, either emtricitabine or lamivudine, or resistance to the non-nucleoside ART inhibitor, and there's no resistance. That means that there was also no drug exposure. And when you look at some of the second line studies, people who had no resistance were much less likely to be suppressed on their second regimen compared to people who had drug resistance at failure to the first regimen. And that's because they failed with maybe imperfect adherence, but still reasonably good adherence. And the people who failed without resistance were much less adherent, and they were likewise much less adherent to their next regimen, despite protestations to the contrary. And so I think, unfortunately, it's very difficult to take at face value what people say about, because there's such a social pressure to say what the clinician wants to hear. And so people will say that they're taking all their medicines, but it's, unless you have drug levels, it's hard to know that that's true.
Yeah, I completely agree. The only one exception is the failure in patient taking cabotegravir lipivirine.
Yes.
But we have not enough information on the reason why some of them are failing.
Right.
So I think that apart from the classical risk factor, but we are starting to see a few without having the subtype A6 or A1 or rilpivirine RAMS or high BMI, they still fail.
Right,
so
right.
But obviously, when we will arrive at injection, if everything will be injectables or in subcutaneous device or whatever, or implants, I think that only in that case, the adherence should be, excluded, problem of adherence, because it's very, very complicated. Would you still consider tenofovir to be fully active in setting off 184V and K65R mutation? This is interpreted as intermediate resistance on Stanford database, but clinical data suggests patients may still be well controlled. Dolutegravir TAF-FTC and bictegravir TAF-FTC, despite the integrase being the only fully active agent.
Yeah. So I think there are two reasons why these regimens are, in fact, still highly effective. The first is that although the virus would be fully resistant to either 3TC or FTC because of both the 184V and the K65R mutations, the 184V mutation sensitizes the virus to tenofovir and to a great extent counteracts the effects of 65R, which is why Stanford considers it intermediate, not full resistance. But the actual data, and here we're really relying on data from the Nadia trial, show that even in the setting of resistance, both dolutegravir and a boosted PI were highly effective as second-line regimens. And so we have probably been underestimating the activity of these nucleoside combinations. And I believe it's largely because of the effects of the 184B mutation and its sensitizing effects. And so for that reason, I don't think there would be any concern about using an integrase inhibitor-based regimen, even with those two mutations present.
I would be confident probably if a patient is a switch with an undetectable viral load or very low viral load. So this could be changed dramatically if the patient has 100,000 copy, 500,000 copy. I mean, it depends, because just to get someone undetectable when he has 1,000 copy, it takes much less than if he has 100,000 copies. So I would say that switching an undetectable viral load patient and a suppressed patient, or someone with a very low viral load, maybe these second generation integrase inhibitors could be enough to reach undetectability. If the patient has a high viral load, I would not be so confident. It would not be my choice, I have to say. What is the lowest viral load to be non-transmittable? There are not so many data, I have to say. What we say is your viral load should be undetectable. Actually, they talk about less than 200 or less than 1,000. But for example, for the delivery, to have a vaginal delivery, you could have less than 1,000 copies, or there are 200. But usually I say that someone is, because the viral load, when it's detectable, it's a dynamic situation. It could be one level today, but tomorrow it could be the double. So I think that if it's not undetectable, I usually, talk about a lot of cautious.
Yeah, this is a challenging area, because especially for people who have persistent low-level viremia, where there's nothing that you can do to make them undetectable. Adding more drug is not going to lower the virus load. I think, the best data that we have are the data that Tom Quinn generated, it must be at least 20 years ago now, from the Rakai cohort, where they showed that, in discordant couples, there seemed to be a threshold for risk of transmission at 10,000 copies. But they weren't able to stratify the risk, by progressively lower and lower levels of viremia. It is likely that people with only a few hundred copies are at a minimal risk of transmitting. I don't know that we can say that they are at absolutely no risk of transmitting, but certainly, once you get to several thousand copies, I would be much more concerned about risks of transmission.
In a patient who is lost to follow up for about 3 years, was on tenofovir, diproxil fumarate, 3-TC, atazanavir, ritonavir, prior to the fall. What regimen do you suggest for him to recommence his ART regimen? It depends if he failed something before. For example, if he was on efavirenz. I mean, if he stopped the medication and he didn't develop any resistance, probably he could start with a second generation INSTI. What do you think?
Yeah, I agree. I mean, I guess my first question would be, why was this person on boosted atazanavir 3 years ago? Because by that point, we had pretty much moved away from boosted PIs to integrase inhibitors. So if there was no contraindication to the use of an integrase inhibitor, I would certainly agree with Dr. Mussini and use one of the second generation INSTIs as the next regimen. If they couldn't tolerate the integrase inhibitor or had resistance to the integrase inhibitors, then I would use a boosted PI regimen, but I would consider a fixed dose regimen of boosted darunavir with FTC and TAP, only because that's available as a single tablet and would be simpler for the patient than having to take what this regimen here would be basically a 4-tablet or 4-pill regimen. Because
I would not restart with it.
But it depends a lot. It may depend a bit on the part of the world you're in, because fixed dose formulation of darunavir, CoB, FTC TAF is not available everywhere.
So with drug levels, how can one know that is poor adherence rather than poor absorption of the drug? We know that the patient has a low level of drugs, and it's difficult to discriminate between them. It's just, I think that we should talk to the patient and try to understand with him, no?
Yeah, I mean, obviously there's a range. All the PK parameters have a range of values that are found in patients, and we always worry about people who are at the bottom end of the distribution. At steady state, I mean, first of all, poor absorption is much less of a problem compared to rapid metabolism, unless there's an interfering substance like we spoke about with the di and trivalent cations, or with some of the drugs if you're taking it without the right food, like rilpivirine needs fatty meal for absorption. So it's pretty uncommon to have poor absorption. And at steady state, I would expect you would have good trough levels. If you were looking at you'd have to look at the peak concentrations and time to peak if you really wanted to assess drug absorption, I think.
Yeah, and also drug absorption, just if the patient underwent surgery, for example, a gastric lymphoma, but there are not so many. I mean,
or bariatric surgery might be.
Or bariatric surgery, yes. Is it possible to develop resistance to dolutegravir-containing regimen within 1 year of initiation with perceived 100% adherence? I mean, we have shown you the data that is very rare to develop resistance. And the perceived 100%, I don't know. For example, the patient who developed bictegravir resistance was a patient with a PML who cannot swallow, and so they were given, I mean, it's very complicated to develop resistance to these drugs. So in general, everything is possible because the data on dolutegravir monotherapy show that it's possible when there is a bad selection of the patient to develop resistance, but it's very, very rare.
Because the last question we have time for is asking about the difference between a virus load result that's lower than the detection sensitivity limit or versus target not detected. From a practical clinical perspective, those are the same result. Because even if somebody has target not detected, if you took 10 milliliters of their plasma and concentrated it, you would be able to find virus in most patients. And so there's an artificial distinction here. It's really partly a regulatory issue that they're able to measure or detect some virus, but can't say what the copy number is. So they say it's below the limit of quantification, as opposed to not having any signal at all. But there's no difference in terms of the risk of subsequent treatment failure. And I would consider both of those persons to have full viral suppression. What we're really looking at is just release of virus from activated cells from the reservoir, but those viruses don't go anywhere because the drugs on board are preventing people from having ongoing rounds of replication.
Yeah, I completely agree.
Thank you very much to Dr. Kuritzkes and Dr. Mussini, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.